Treadmill exercise ECG testing is typically performed to evaluate exercise tolerance or to evaluate for exercise-induced myocardial ischemia or arrhythmia. An IV is not needed for this procedure. Ensure that the equipment and supplies needed for treadmill exercise ECG testing are present. This includes the treadmill, ECG monitoring machine, ECG acquisition module, blood pressure monitor, and resuscitation capability such as a crash cart. A qualified medical professional, such as a physician, nurse, or exercise technologist, is present throughout the study to monitor the patient. A brief history is taken to document symptoms, atherosclerosis risk factors, current medications, and review basic laboratory findings. Review the clinical indications of the treadmill exercise ECG test, explain the procedure to the patient, and obtain written informed consent. Patients should refrain from oral intake 3 to 4 hours prior to the procedure. Medications which may impact maximal workload, such as beta blockers or calcium channel blockers, should be held for 1 to 2 doses unless the study purpose is to diagnose ischemia while on therapy or the risk of an adverse event off medication is deemed too high. In order to do the test safely, patients must be comfortable walking unaided on a treadmill. Patients are counseled on the risks of the procedure, such as angina or arrhythmia. Rarely, treadmill exercise ECG testing results in myocardial infarction, but the risk is less than 1%. Contraindications for this procedure include recent myocardial infarction, high-risk unstable angina, uncontrolled cardiac arrhythmias, symptomatic severe aortic stenosis or heart failure, and poorly controlled hypertension. Calculate the patient's target heart rate. Maximal predicted heart rate is calculated as 220 minus the patient's age. The target heart rate is 85% of the maximal predicted heart rate. In this case, based on an age of 27 years, the target heart rate 85% of 193 or 164 beats per minute. The patient is set up for monitoring. Skin preparation with alcohol and gel improves lead contact, ensuring that leads will not dislodge during the study. ECG leads are placed in standard positions. The ECG acquisition module is connected to the ECG leads, and a baseline 12-lead ECG is recorded. Care is taken to ensure a tracing from all leads with minimal artifact. The MD or RN reviews the baseline ECG for baseline abnormalities. The ECG acquisition module is secured around the patient so that it does not become dislodged during treadmill use. A blood pressure cuff is placed securely on the patient for monitoring during the procedure. The patient is asked to place his feet on either side of the belt prior to initiating the treadmill belt. Baseline heart rate and blood pressure are recorded. When the exercise protocol initiates, the patient is instructed to hold onto the treadmill bar to reduce the risk of falling. There are several exercise protocols used in clinical practice. We typically use the Bruce protocol, which is programmed to increase both an incline and speed in 3-minute stages. Blood pressure and heart rate are recorded during the last minute of each 3-minute stage. Periodically, the patient is asked if they are experiencing anginal symptoms. The patient is advised in advance when the treadmill will increase in speed and incline. During the study, the ECG is monitored for arrhythmia. Unless the patient is unable to continue the protocol, exercise is continued until at least target heart rate is achieved. Beyond target heart rate, patients are encouraged to continue exercise until fatigue or other symptoms necessitate exercise termination. If the patient does not achieve target heart rate, Negative test results should be recorded as a non-diagnostic study in the context of the workload achieved. Treadmill exercise should be halted by the supervising provider with any development of severe angina, ataxia, dizziness, systolic blood pressures over 220 millimeters of mercury, a hypotensive response or decrease in blood pressure of 40 millimeters of mercury, concerning ECG changes, or significant arrhythmias. Once the patient indicates that they need to discontinue exercise, the ECG technician slows the treadmill to a slow walking pace for the recovery period. Blood pressure and heart rate are recorded, and the patient is interviewed for anginal symptoms. The patient is monitored until heart rate returns to baseline. The ECG leads, ECG acquisition module, and IV lines, if placed, are discontinued, and the patient is dismissed from the laboratory. The physician interpreting the study reviews results. Based on total exercise duration, a nomogram based on age, gender, and degree of physical conditioning provides an estimate of functional aerobic impairment. The heart rate and blood pressure response to exercise are reported, along with any arrhythmias. The standard ECG criteria for ischemia are ST segment depression, that is, greater than 1 millimeter and horizontal or downsloping. Persists for at least 60 milliseconds after the end of the QRS complex. Is seen in 2 or more contiguous ECG leads. If stress-induced ECG abnormalities are seen, patients should be monitored until these abnormalities normalize. The stress test is considered abnormal if ECG criteria for ischemia are met, the patient develops angina symptoms or arrhythmia, or if the patient has significantly decreased exercise tolerance, typically shown with inability to continue exercise beyond stage 1 of the procedure, or with a functional aerobic impairment that is 20% less than normal. A final report is generated which should include comment on exercise duration, workload achieved, description of symptoms during the study, hemodynamic findings during each stage, such as heart rate and blood pressure, and the ECG results. A copy of the final report should be sent to the referring provider.